Well, hello. Good to see you guys. I'm so sorry I had to record this video instead of doing the presentation live, but I accidentally double booked myself and I did not want to disappoint you guys by not showing up. So I had to make a video instead. So it's kind of live. It's the day before you're seeing it. Something like that. But anyway, we're going to talk about one of my favorite topics today, which is developing an MPI toolkit and all the HIM field work that went into it. Looking at modern techniques and solutions for solving some everyday HIM problems around data duplication, data quality, overlay records, patient search on patient access, and so forth. I'll cover a lot of new technology, a lot of new approaches, hopefully, some new ideas. And let's spend the next 90 minutes or so to look at some of this data. I will be available for questions. I have my email address and everything available. And I do apologize again for not being live, but I did get the content for you, so at least I can do something. So stand by and we'll begin the presentation. Okay, so we're going to talk today about what I'm calling HIM field notes. And what it is, it's a collection of methodologies and best practices that I've observed as I've done HIM data cleanup and data integrity work all across the country. And also, it's some of the original ideas that I've been able to generate as I've been working in this industry for about 7 years. Last year and this year, I'm the co-chair of the CHIA Health Data Integrity Committee, and that actually sponsored the work that myself and my team built, that eMPI toolkit. I'm also a member of the CHIA Editorial and Advisory Committee, which is a group that we organize and help get the CHIA Journal published. It's a very good journal. And I'm the professor of health informatics at Charter Oak State College. I'm developing new coursework in patient matching and patient search for patient access solutions. And hopefully some of that information will come through today. And my day job, beyond all that work, is I focus on applied research and publications for healthcare IT matters, specifically problems that are very, very hard to solve for most organizations. If you can't tell, I'm a bit of a nerd. I have a master's degree in computer science, Johns Hopkins University master's and Randolph-Macon College undergraduate. And I use that information to help bring in new ideas from other industries. I've been in healthcare, as I said, about 7 years. Before this, I was in national security and finance, and I did a lot of work in the .com world too. And all of that information together, all of that background, I should say, is directly applicable to what we're doing in healthcare and HIM, patient access, and revenue cycle today. Some standard disclaimers, of course. I've done my best to prepare a presentation that has accurate information that hopefully will be of some value. But I'm not giving you specific advice for your circumstances, but we're talking in general. But I do recommend, if you apply any of the techniques we talk about, that you leverage professional advice, because the topics we're discussing are quite complex and they typically do require individuals with expertise in what we're discussing. I've taken every precaution that I can to make sure the data is fact-checked and it's valuable, and hopefully you'll find it the same. So let's talk about patient safety. It's my general theme for the topic today. And it should be on everybody's mind because that is what we're supposed to be doing, right? Protecting the patients. And I want to talk about patient safety through the concept of error prevention. That's the backdrop for everything we're going to talk about today. Our goals today, I'm going to discuss what I think of as a data integrity continuum throughout the whole organization from start to finish. And I want to talk about and highlight the importance of error prevention and why it's has such attention from myself and my team. I want to bring up and review the root causes of duplicate patient records as well as overlay records. And part of the overarching concept of prevention, I want to bring up what it means to find patients. What protocols do we use? What technologies do we use? How we can improve finding patients even with the technologies we have today, and also give you a preview of what technologies are coming. So we can really find patients every time that we're looking and we don't have duplicate records, simply because. And then lastly, I'll give you some previews into the EMPI toolkit that I wrote for CHIA. So my concept of a data integrity continuum is that it goes through the point of registration and scheduling to patient identification during an encounter. And absolutely, this is the beginning of driving patient satisfaction, right? The clinical encounters are really critical for the patient to feel like they're getting attention, like the physician or the clinician knows the patient, knows their problems. And nothing would defeat that purpose more than if the patient asked a question about a prior visit and that data is not available. Or even worse, the patient points out, no, doctor, I don't have twins. I've never even had a child. And I'm giving you real world examples from situations I've seen and I've read about that, yes, indeed, this happens. Females or even others are simply brought information to their attention by the clinician that has nothing to do with their background. And that is not a good solution, I think, or a good situation for giving patients comfort that we know who they are. I believe the data integrity continuum flows through compliance too. And I'm talking about regulatory compliance, helping to identify patients so that we can serve up their records as part of the new 21st Century's Cures Act regulations that require us to pass on the patient information, medical records rather, to a patient or their provider upon their request electronically. That regulation is in effect now, and healthcare organizations are really trying to catch up with coming into compliance with it. And I will say, we'll talk about this at length, but clean data, making sure your data is as good of shape as it can be, will help avoid the fines and the issues with finding patient records that, frankly, are difficult to find in a lot of circumstances. And also, this is important when we consider mandatory reporting for healthcare organizations, say right now in the times of COVID. I know California, for example, has to report every single, every single case of COVID for patients that are admitted and discharged for the hospital on a weekly basis. This is for acute care situations. And they're really trying to track the effectiveness of the vaccines that have been given to the patients. And the Department of Public Health just put this out in July for California, and it's yet another reporting regulation on top of all kinds of other reporting that relates to COVID and others. Reporting to CMS and HEDIS metrics and all that are challenging too. And you have to have good data in order to have good reports. So that's regulatory. And lastly, and some might even argue most importantly, at least from a financial perspective, revenue cycle and CFOs often have the last word on things. So we need to make sure that we scrub claim data. We can lower the AR days, the accounts receivable days, and really importantly, reduce denials. So ultimately, we're compensated for the services that we give. And that is I think the last part of the continuum that I've envisioned for data quality. It's at every step in our healthcare ecosystem. Now let's talk about the leading causes of death in America. Heart disease, as you may have known, is number one. And cancer of all forms takes place number two, kills more Americans than almost anything else other than heart disease. And would you believe it, errors in medical records is the third leading cause of death in America. Now, That was before COVID, and COVID has since bumped up to number 3. But we do all believe, I'm sure, that COVID eventually will be handled as we get more people vaccinated, more skilled in treating patients, and ultimately we will have a situation where it won't kill as many Americans. So I do believe it's going to drop back to lower than 3rd. But the real point is that medical errors, and we're talking really data errors specifically, are a cause of death in America. But think about this. I'm going to use my photo as an example, but this is a real world news story that I read not too long ago, sometime the past year. But there was a patient who had a DNR, do not resuscitate order, in his records. Later, he changed his mind and decided, I think I'll let the doctors resuscitate me. But of course, you're going to guess what happened. He had a duplicate record. A later encounter, that patient went into code blue, and as a result, that patient did indeed die because he wasn't resuscitated. And this was against his wishes, but they did not know because the records were duplicated. Crazy story, one of the craziest I've heard. And I collect these crazy stories, and that's up there. But you can see kind of the weird things that happen when you don't have a complete longitudinal copy of your medical record available for the clinicians during the encounter. There's a study by Johns Hopkins University, about 2016, the study, where they said 250,000 Americans died every year due to medical errors. 250,000. And some estimates even put that as high as 400,000, right? And if you do the math, that's about 4 deaths per hospital per year. 250,000 divided by about 6,000 hospitals, plus or minus. That's a lot of patients dying because we don't have the data correct. It's not all patient identity errors. Some of it's medication errors or dosing sizes, but a substantial percentage of it is patient identity. But if we have any motivation to fix this problem, especially when we consider patient safety, 1 every 3 months die because of a medical record error. And we do have to acknowledge, right? This is a hard problem. Many patients share the same date of birth. Many patients have similar surnames, or there's very common names like mine, James Hoover, and some are much even more common. But nonetheless, all of this leads, and then the data errors inherent in just typos, etc., and misspellings. All of this lead to duplicate and overlay records, which is the root cause of some of these deaths we're talking about. And so we have to really think about how can we solve this problem, and really what's the relation to others in the organization that might think about the problem a little bit differently. I turn my attention to revenue cycle a lot of times because they do tend to have the ability to get budget for things. And if we speak their language, it's just the denials alone or the delays in payments alone are high, very high. It's a multi-million-dollar problem for organizations. 33%, roughly, denied claims are simply due to patient data errors, identity problems. And then if you factor in the cost to fix those claims, we're talking a lot of extra time to get paid, if you get paid, and then a lot of cost inside the hospital to fix it. And one of the first things I noticed in healthcare was the search tools in EHRs were not effective finding patients. That's the root cause of our duplicates. That we don't necessarily blame the front end people for every error, because a lot of it's just simply due to their tools. The job's difficult. Those tools are old, as I'm talking about. We're going to talk some about search protocols, that they might be out of date. That makes it harder for the patient access team to find patients. And the data is a mess. That's my real big key. If we don't have clean data and we don't have good search technologies to find patients, we cannot expect miracles out of our front-end staff to find those patients. And lastly, America is a big, inclusive country. And we have people from almost every place in the world here. And that means we have names from different languages with different scripts, writing systems, different ways to pronounce letters and words and tones. All these things contribute to difficulty in spelling non-English names. And even Spanish, the lack of ability for most people to put the tilde on the end and other characters that are not the core English character set means that we don't always get patient names correct. And what I like to say, because I'm a computer scientist and I express things maybe a little bit differently, we don't want to have to train our front-end resources to be linguists, to really understand the nuances of all the names in the world, all the types of names. And I'll get into that in detail a little bit later. But let's talk about the tools for a second. And then we're going to get into some HIM policies soon. But I pick on the National Association for Access Managers and their website, because they have a very typical search capability. If you make any mistake in any of the typing, it's just not going to find what you're looking for. And we can go over this time and time again. But if you make a mistake in anything, then the words, the topic you're looking for is not found on websites. And we're going to talk on the big web in a minute. But most websites have this limitation. So I want to think about this. The search tools that we use in healthcare are just like that website. Just like it. If we make a mistake in the typing of the name, we can't find our patient. Unless what we type in is perfect and what is in the MPIs are perfect. And do we really believe that the MPIs are perfect? No, of course not. And as business leaders, though, do we always type perfectly, right? And if we don't, how can we expect our staff to type perfectly or to overcome the MPI problems? And all of that is the backdrop to say is that our EHR searches are problematic. If we don't type things exactly, we will not find the patients we're looking for. Some people typically learn to be very clever with searches and only type the first 3 letters of the last name, for example. And I'll talk about that when we get to search protocols. But generally speaking, that's not a good idea if you really want to find the patient every time. And I'll go through why. I consider EHR searches to miss the mark in the problem that they're trying to solve, and that is finding patient records. And the reason really, frankly, is simple. It's just old technology that EHRs deploy are literally from that era. We can't assume that the data is ever going to be perfect. In fact, I say it'll never be perfect. And frankly, neither will the users. I'm a terrible speller, but yet, if I don't spell a patient name correctly, I can't expect the current search systems to find it. It's just not possible. And these data errors that go into our MPI, it's not just that they pop up overnight. They're one error here, one error there, one error, as we bring in, or 10 errors as we bring in a new MPI source when we acquire a new practice or merge with a new facility. And ultimately, all those errors ultimately take us to the point where we have records that we can't find. Thus, we have duplicate problems, duplicate record problems. But I made a little poem for you to remember this. It's kind of silly, but data errors equal search failures. So we really should be looking at the left side of that equation. we know we got a lot of search failures, but maybe we should address some of the data errors because they cause duplicate records and impact patient safety. They also impact the revenue of the organization, create leaks, the denied claims, or the delay in processing them because we have to fix them, delay in getting paid. AHIMA and the HFMA, Healthcare Financial Management Association, both put the duplicate record problem at 8 to 12%. That research is a little bit dated, 7-8 years now, but I do believe it holds true. Some estimates are even higher than that. I routinely see duplicate records in the low 20% range. But let's just consider this math. If we have an average of 8%, that means 1 out of 12.5 records that we search for are gonna be partial records. We're gonna get a duplicate, part of a duplicate record. And if we've got 12% errors, 12% duplicates in our data, that means 1 out of 8.3 times we look for a patient, we're gonna get a partial record. That's greater than 10% of the time. That's really bad. And for some of the hospitals I've seen at 20% or plus or minus a few points, that's 1 out of 5. Every 5th patient that we search for is going to be partial records. That's crazy and insane if you think about it. How pervasive these data errors that cause duplicates and overlays, how pervasive they are in every single time that we search. And there's been more research, I should point out, that larger MPIs generally not only have a higher absolute number of data errors, but they also have a higher percentage of data errors as well. Because as our MPIs grow, data problems or data quality problems grow faster than our MPI size does. So the more patients we add, we're going to grow our problem at a faster pace. Many patient records look the same. And even though every patient is supposed to be unique in the MPI, how do we know that? How do we find that patient? How confident are we? And if we do find the record we're looking for, the patient record, are we 100% certain that it's the only record for that patient? Given those ratios, 1 to 12.3 or 12.5, 1 to 8.3 or 1 in 5, the chances of finding a duplicate record are really, really much more than you think about. So what does this mean in practice? In everyday life, what does this mean? Well, let's say we're talking about infectious diseases, right? If we've got partial records for COVID patients or other diseases, and we happen to pick the wrong half, maybe we are inadvertently exposed to something because we weren't taking enough precautions. Maybe we're ordering new tests for patients that we already have results from in another record, which we're not going to get reimbursed for, and so forth. So there's a lot of practicality to minding our P's and Q's and making sure that we don't gamble and just hope that we find the right record or all of the records. We're not in Vegas, baby. We're not. We've got to be careful and we've got to fix this problem. So one of the things I like to do, and this is a best practice I want to recommend to everyone on this call, is understand how good or how bad your underlying data is. How imperfect is it? And I'll give you an example. We can look at something that I'm going to call error proxies. And let's say that we have a known address. We can go in, like the hospital or like a homeless shelter, a halfway house or something. Some institutional address that patients often use for their address. We can then query our database, or MPI, and look for variants of that address to see how many times that we misspelled it, or we've got the wrong street address, or the wrong abbreviation, or something. But from this examination, this query, this analysis, we can then understand what errors we might have across every single data field. If we have a known error if we have a known address that has many errors, and we can measure that, that's a good representation or a proxy of how many errors we have in other fields. And let me give you a real-world example from my HIM field notes, as it were. We had one hospital, not going to say where or who, protect the innocent, but they had 262 versions of this same address. 262. And that's just the number of variants. That absolutely represented 2% of their data, with over 10,000 data errors just in this address alone. So we can assume all of our addresses are going to have similar problems, and every single field is going to have similar problems. And that doesn't mean we only have 2% errors. No. It means we have 2% errors in this field, plus 2% errors in another field, plus. And some records will be compound errors, so we won't count them twice. But you can assume that every single field that we use for patient identity is going to have similar errors. And now you understand how we can build up to 8, 10, 12, 14, 20% data errors. But these error proxies are a really good way to measure this. You can do this with names, social security numbers, dates of birth, telephones, etc., by looking for data that's probably not valid, or looking for common names that are most likely misspelled, and so forth. And because this is all I think about, well, not quite, but I want to distinguish between the type of errors that we have, because we have good old-fashioned spelling errors, as the vernacular goes. Misspellings are when we just don't hear something correctly, or we just don't know the I before the E except after C, that kind of stuff. Or we have some of the non-English names, for example, where we have trouble spelling the patient's name because the characters that make those phonetic sounds aren't spelled exactly the way we're expecting them. And this happens all the time when we translate names from other languages into our English character set. And I'll give you some examples later. But I always thought, right? Every time I write something, hopefully I grammar check it and I spell check it. And that's on a tool that I use, Microsoft Word and PowerPoint and emails, etc. But why don't we have something like that in our EHRs? Why can't the EHRs say check the addresses like we do when we're putting an address in for Amazon, and it gives us all the potential correct addresses for what we're looking for, or it'll reformat them properly. And if we can do that, we can fix these data errors so we get a little bit more on point, on target when we're trying to find patients. Simple things to correct the root cause of the duplicates, which cause us patient safety problems and revenue cycles later. It all starts with one character in the wrong spot. Now, none of this should be new to any of us as a concept. There's a long history of talking about duplicate patient records. But as a computer scientist who builds solutions, I read all the documentation, all the publications. And one thing I've noticed, if anything, on this particular topic, is that everyone repeats the same quotes, the same 8 to 12%. They give the same platitudes, but no one or very few give solutions. And it drives me crazy. This is something we spend millions of dollars a year on, cleaning up records before we do an EHR upgrade, or we have a circumstance where we can't find a patient, then all of a sudden it generates some cleanup activity. And look, as an industry, we've tried, right? We've tried to move to situations where we do data governance and other processes, and that's all good. And as the federal government is mandating that we find patient records through this new electronic interchange that's being built for this 21st Century Cures Act, the anti-blocking regulation from CMS, we're going to spend millions of dollars more in fines if we don't find those records. So it's a problem on all the records. Finding a partial record will still get you fined if the patient reports it because they know they had the encounter. And I've mentioned this a few times, but I want to just put a final point on it. We know EHR search is bad. There have been studies that have shown technology was invented 1 year before my beloved grandmother, who's passed away, was born in 1918. So Soundex is a century-old technology that we still use in healthcare to find patients. It's kind of funny when you think about it, especially when there's much more modern ways to do phonetic matches. And even phonetic matches are not even close to the state of the art for matching patients or searching for patients. So I hope you get my point. This is old stuff. Some of it even older than my grandmother, who's no longer with us anymore. God rest her soul. And we know the outcomes, right? We can't find the patients. They create the duplicates. Or we generate overlay records, which we don't talk about a lot in industry. And that's a big problem. I have a whole new presentation I'm developing on solving the overlay problem. This technology-based problem, these century-old technologies, these 60-year-old technologies, these 50-year-old technologies to find patients, to match patients, just are not cutting it. That's why we still have these duplicate records. And EHRs do not fix themselves, right? Once the errors are introduced in the MPI, they stay there for a long time. These small little data errors have very long life cycles. So that's something to think about. We get it soon, early on, for the entire life of that data record, it's most likely going to be there, the error. The challenge is when we have compound errors, more than one error in a record, it greatly complicates patient search and patient matching because the technologies we use do not do well when there's many errors in a record. And we can think of that like the address and name being wrong or the date of birth being wrong. And we can also think about it in terms of missing information. There's a whole new suite of technologies out there now that help you fill in the gaps in the data. Some customers call it data hydration. Other companies call it data enrichment. But one of the solutions to fixing patient matching and search is doing data enrichment to help reduce the impact of compound errors in your searching looking for patients. So if we're not finding errors or finding records because the current search technology is having problems, one of the things I'm going to recommend is to do a deep cleaning. To err is human, as they say, and we all know we're going to make errors. And these errors will persist. So let's get the vacuum cleaner out and let's clean this data up before it's too late and we create duplicate and overlay problems. Fundamental problem, deep clean the data so we don't have the search problem, so we don't have the duplicates. Now, I do get some people that challenge me. Say, oh, we have Epic, it's great. And they beat the chest. It's the best thing ever. Or we have Cerner. Nobody beats Cerner. It's the best. Or we have Allscripts. It works just fine. And I have customers with all three of these systems. And then I have customers with Meditech that admit, we know it's old. But it's what we got. All of these systems have one thing in common. They're monolithic. They're big, they're massive. They're doing many, many, many things. And it's not to say that, it's like Stone Age technology, even though we are talking about some old technology. But what we're really saying is that these systems, all of these systems, simply can't do every single thing as good as special purpose solutions. We've moved away from the specialty systems where we had registration, we had cardiac, we had pharmacy systems, we had data storage systems. Now everything the trend is to be pushing them all together in one big EHR. And companies like Epic and Cerner and others, they don't want other companies in there working with them, so they do their best to keep them out. And what happens is we just don't have the best solution for every single problem in healthcare in one piece of software. And matching and search are the best example that I can give, because they're very, very specialized, they're very mathematical, and we are using really old solutions, thus we have the duplicates. So the proof is in the pudding that it's not state of the art, right? And it's not like we can't plug in external systems to solve these problems. We do have a lot of external matching engines out there, patient matching solutions. And all these systems are downstream from the EHR, and they share data via interfaces, just like we do with finance and radiology and labs. Information goes back and forth all the time. So there's no reason we can't consider doing some things smarter, better, if we have the technology that's available. So just to kind of put a checkpoint where we are before I dive into some new stuff, is the current state we all admit. Raise your hand if you disagree, although I can't see you. you can email me. All MPIs have data errors, and many MPIs have a lot of errors, right? And these duplicate data errors and overlay errors cost lost revenue and even lost lives. Can't overemphasize that enough. There's a lot of reasons for these errors, and it's not always the front end people. In fact, it's just as much, if not more, a technology failing than it is a staffing problem or training problem. We're never going to train our way out of this problem, so we have to really look at doing some different things. And search, finding patients, is really the focal point, the center of the problem. If we can't find the entire patient records, then we're going to have challenges with the treatment. So I presented the problem, right? And it would be very ungentlemanly like if I didn't present a solution to the problem I'm pointing out. And this is where my background is particularly unique, because I have not spent a lifetime in healthcare, just 7 years. But I do know a thing or two from other industries as well. And I do know that we can learn from industries to help improve the state of the art here in healthcare today. So let's connect the dots. If we all agree with the premise that medical data is full of errors, and I also think that all of us has probably used the internet search before, Google, Yahoo, Bing, DuckDuckGo, and all these other internet searches, but Google being the predominant leader. We know that we can find anything we want on the web. And I wonder, what should we use to search medical data that has errors? about it a little bit more, maybe I'll come up with an idea. Oh, internet search technology, of course. I'm being silly. But the idea though is the web is full of errors and it's vast. And yet Google can find anything that we want in microseconds. So why can't we do that with patients? And this is why I talk about modern search a lot, because that's the fundamental principle. If we consider EHR search, right, versus modern search or web search, the web has hundreds of billions of web pages, and the typical EHR might have 1 to 2 million records, some more, some less. And EHR search even has an advantage because the subject that we're searching for is often right in front of us or on the telephone. They can help. And EHR search also has an advantage because medical record search is a very limited domain. We only have to look in a few fields in a small database for something that we know is a patient. That's a lot different than doing research, looking for information on a paper you're trying to write, or trying to find a movie down the street, or trying to find a part for your sewing machine or for your car. It's a lot easier to do because we're only looking for patients. And all these things, we would think that EHRs have the advantage, but they don't. And I kind of joke when I call search modern search, right? Because the web is getting old like me. It was invented in 1989, just a couple years after I got my graduate degree. And the original web predated when we had GUIs, graphical user interfaces, Windows. So it's really old, the web. And internet search, what I'm going to call modern search, came out around that same time, in 98. And I worked for a company, Digital Equipment Corporation, that reached the predecessor to Google a few years before that, called AltaVista. And I applied AltaVista at NSA, National Security Agency, when I was young engineer. And so I will tell you that modern search, in quotes, has been around for a long time. And let's put that on our healthcare IT timeline. That's right around when HIPAA was passed, the Health Information Portability Act. And Google was after HIPAA. And all of that was 2 decades prior to the ACA, the Affordable Care Act. And now that we've gotten into meaningful use programs, and now we're moving into, beyond that, the information age where we share medical records between systems. That's what the ONC CMS final rule is all about, for anti-blocking, making sure patient records can be downloaded to the phone or to a provider at the patient's request. It's not optional, man. It's something that we have to do. And all of this is well after the advent of what I'm going to say, modern search. So I think about what happened the past 20, 25 years. Why has it taken so long and we still don't have a modern search capability? It's a question to ponder. But my job, thankfully, is not only do I get to ponder these questions, but I get to think about, write about, and teach about, and then ultimately create what a modern search tool would look like in healthcare. And I think there's a couple things. It has to be fast, just like Google, right? But it also has to be accurate. We cannot afford to be fast and not find patients or find the wrong patient. So speed and accuracy is critical because we have patients right in front of us that need attention, need to be registered. But also we have to acknowledge the elephant in the room. Our front end staff is not an organization that's highly trained more often than not. So the tool should be like Google, user friendly. No one takes a class in Google, learn how to use it, right? We just get in and we use it. intuitive. And I submit to you that patient search should be identical. And one thing patient search must be is smart, because it has to work with errors in the MPI. That's super, super critical. That smartness and errors in the MPI means there has to be a large amount of fault tolerance, so we can still find patients even with the MPI errors with that long life cycle of data that never get corrected, but yet we can still find our patients. That's really super important. Those two characteristics, smart and fault tolerant, I think are critical with the FAST. This has to do with things like data quality, data standards. We're going to be facing that quite a bit when we have providers that say have a middle initial instead of a provider that has the full middle name. I've seen both. Providers that put the junior or the generational suffix, the third or what have you, in the last name instead of a different field. Providers that have a space in the compound names or not for, say, women that hyphenate names, or Hispanic people that often have two last names or sometimes two first names even. Misspellings that we know happen all the time. Words that sound alike but are spelled differently. I've even seen my name spelled G-Y-M, Jim. Makes me laugh, but I saw it one time. And so forth, right? America is a huge multicultural country, and our IT systems cannot only think in English words. Our name fields, our ability to find patients with names, should be much more inclusive, because we're talking about safety, satisfaction, and getting paid for our work. So we should be good at finding the patients. Of course, there's really obvious things too, right? It shouldn't matter where we put the names. If you search with Google, you could put words in any order. It doesn't matter. It still finds what you're looking for. And the same thing should be true with patient names. I'm going to get into that, especially as we talk about some different languages in a moment. The name also has to be smart with nicknames, right? There's so many different names for Robert, different nicknames. And someone might use them at any point in their life. When you're young, you've got part of the name, a different name, it's diminutive, and you get older, you change it, maybe Bob and Robbie and Robert. Nicknames, not only English, not only Spanish, but very common nicknames in other languages as well to find what we're looking for. And we have to be, I think, pragmatic too. We cannot expect our front-end staff to realize that, say, Paco is a nickname for Francisco, or James or Jim, or anything you can pick. So this is where the software should be helpful. The search software should be smart. There's more languages in the world than Spanish and English, which are the predominant languages here in America. So we have to really be clever about the linguistic assist that our software uses to find patients. Now, we have even English names that spelled differently but sound the same, homophones. Jeff with a J, Jeffrey with a J, and Jeffrey with a G are two of the best examples of legitimate names that are spelled very, very differently. That also fail on the most basic century-old test for finding patients, Old Soundex. If the letters don't start the same, you already did not find your patient. And we talked about those 3-letter searches earlier. We previewed at least. I'm going to save it for later. But if we're already starting with a difference in the first character, we have no chance of finding that patient. First and first. I know it's the same. You know it's the same. Computer sure doesn't, because they're not equal. So our search should make sure that these two words are the same. Current state of the art is they're not, at least in healthcare EHR searches. They're just not the same. And this is a real key point, is EHRs are inherently structured for English, and that impacts all kinds of patient safety issues. I want to give some examples from non-English names, but the name structures for non-English names can be different. The order of the first and last name, for example, is not always first and last. So that's a problem. There's also a challenge with middle names, and that creates assumptions that every name's a middle name. So when we get into situations where we have Vietnamese names, say, we have to go through a lot of machinations to find these 4 names are not compound names, but it's a middle name. Well, is it? It's actually 2 middle names in this name. And if we have a regimented data structure that assumes, certain things about names and spaces between names and what they mean, we almost would never pick that there's 2 middle names for this particular patient. But the EHR, the search rather, will fail if we do not have the right name. That was Vietnamese. In this example, it's a Korean example where the names are syllabic, and we see 3 names, we might put 1 in the middle, but guess what? That's incorrect. The likelihood is that that's part of their first name. And again, this is not true for every single name, but I'm just speaking in generalities on the languages specifically. And all of us have patients with these names of origin. And if we don't get the name right, we will fail to find the patient. Some of my favorite examples are Hispanic names, where there's multiple names for not only the first, but also the last. And Smart Search should consider that, because the patient might not have the middle name Maria Lopez in the middle name, and they might not even have the middle name Maria, right? They might not even have a middle name, but yet this is their name. And when we see it all mushed together on a driver's license, there's no middle name section and a last name section and a first name. This is up for interpretation by the registration clerk or the software that's scanning the driver's license. And as a result, we get these wrong quite a bit. I see it all the time. And these patients also are challenging because sometimes they don't use every single part of their name at every encounter. Just the way it is. And our software that we use to find patients should be cognizant of this possibility and make sure that we're looking at all the possible variants, as well as the punctuation differences. And we have to consider misspellings in every single name on top of that. And don't forget nicknames. You see, it's very complicated very quick. And this is why we need some smart search tools on the front end to do the thinking for the registration and others that are searching for patients. Let the machine work for us rather than us work for the machine. And spelling non-English names is challenging. This is a process called romanization. Often these names create spelling challenges for anybody, and myself and others, because what we hear is not often what we type, and even when the names are romanized, they're translated to a much simpler version typically than what is the native language. So these 3 different names with entirely different pronunciations ultimately are translated to the same word in English. And now we have increased our chances of mixing up patients because we've reduced the namespace from 3 to 1, at least for this particular name. And we will potentially have overlay records or duplicates as a result. So to put a final point on this, it's really, really difficult and complex. I think you're getting the sense of it. And we know we cannot train our staff, our HIM staff, our patient access staff, to really be highly, highly adept at these linguistic issues. So our software really should do the thinking for us. And those phonetic translations of SoundX and others, well, that's a partial solution. But modern search needs to go much, much deeper. And just like we use linguistics for coding, we use natural language processing. That's a linguistic technique. We need to do similar things on the front end to make sure we're finding patients. One of the cool things that I've observed, we do come across patients with one name. And I'm going to have a hard time pronouncing it, mononymous, mononymous person. But nonetheless, it's very common in the world, and there's lists and lists and lists of famous people. This is just a cool thing I picked off of Wikipedia. Cher and who else? Teller, Penn and Teller, of the magician group. On and on and on. It's not uncommon for people to go by one name. In fact, in many parts of the world, they do not even have last names. There was no need for last names. It was not common. Our country, as we give visas for those coming to America, for example, we have adopted a solution to fill in both fields of our software that require both names. So they use, the State Department uses a convention called FNU, First Name Unknown, and they put the single name in as the last name. I have seen, and this is the standard for US visas, right? So I do recommend we adopt that standard when we have single name patients in our databases. I have seen some policies and procedures and even some publications that recommend repeating the name first and last. But I say no. I think that's entirely wrong. Their name is not Geronimo. It's just Geronimo. And if we put FNU in front of it, then now we know we have a patient satisfaction way to improve patient satisfaction is that we know that the person just has one name. Now, I talked a lot about earlier what modern search should be and why we need it to make sure we reduce the data errors in our daily work that will improve satisfaction of our patients, improve their safety, hopefully prevent people from not making it when they have two different records and they're conflicting or maybe competing information, like that poor gentleman with DNR in his older part of the record. So modern search is something that I think has great applicability to healthcare, borrowing from other industries, as I talked about, to improve what we do in healthcare. And I think it's best if I just give you an example of what that is, and we'll explore how it works on the internet, Google search, and get an understanding for how that applies in healthcare. And what I'm looking for, or what I think is a critical thing, is the search should work even when there's a lot of errors. And not just in one field, but many fields. So I do this demo and this presentation a lot where I take this poor lady's name, Janet Montague, and then I perturb it. I reverse the first and last name. I start introducing different characters in the name till it's not even recognizable. And then I introduce more data in other fields and help find the patient. And do that over and over again, perturbing each field, introducing more and more errors in the record that we're searching for, to basically help us find patient records or illustrate how we find patient records when there's big errors inside. And I think that's really where we need to get to in healthcare search. Because while we're not going to have many patients with this many errors, nantiglubinit on 246 Sivith Avenue, and we're looking for Janet Montague on 2406 7th Ave, We want to have a tool that's powerful enough to find it because it'll work with the more simpler cases rather than something this complicated and this crazy. So I spoke a moment ago about how does this work? How does modern search on the internet work? And how does it apply to healthcare? Well, first off, I want you to understand that it works because we look at patterns. We're not doing exact text matching. And it should also be obvious that it's necessary because we have a lot of spelling errors or typos in our data that can be resolved if we have a high degree of fault tolerance still matching the patients. That's not common in today's healthcare search. It's very common in internet search and other industry search. But what we're looking for is to have just enough of a pattern that's unique and appears frequently in the data to make sure we have the right patient. And that fault tolerance that I'm talking about is built in because of the pattern matching approach. I mean, simply, this is just like Google. It scans all the websites in the world and builds an index. So every time you're trying to find movies that are of a certain type, it also knows where you're located and combines all that data together with these profiles that Google has pre-built of the web pages, so it can then find your data very, very quickly. And in the same way, in an analogous manner, modern search should profile the medical records so we know what kind of patterns are there before the searches even occur. You can find it fast and highly accurate. And simply, you can visualize, do the patterns line up? If the patterns line up enough within a certain level of tolerance, then we can say that the records match. It gives us fault tolerant search that will find more records. It's almost like magic, and that's something that we can adopt from other industries to make our data errors go down in healthcare. I know from working in the field how bad our data is. That's why I think about solutions to fix it. Less duplicate records, very critical. But even more cool is because it's patterns, we can bring in clinical data, unstructured data I should say, that can be used in patient matching. The clinical notes, in other words, are valuable pieces of a patient's identity when we're trying to disambiguate between two patients' records. And this modern search I'm talking about is very, very flexible. We can use it for many different approaches. One of the things that I've seen in the field, organizations using their matching engine just as a QA tool, as a gate. Every time patient registration tries to register a patient, it runs through the matching engine. If it does not match other records in the system, then we let it through. The example, though, is when we do have a patient record that's trying to be registered that matches an existing patient, we can say, you know what, let's hold that record off to the side. Let's review it before we allow the record to be completed and entered into the EHR. Or we create the encounter on the existing patient record. This is some of the ways we can engage our current technology, in addition to newer technology, to solve these problems. That clinical data is really valuable for disambiguating patients. We can use blood types and allergy lists, and medicine lists, and so forth to make sure we have the patients that we're looking for. Or when we're matching, we have a higher degree of a match. And then expanded patient matching on these clinical data types, I think is really a hallmark of what search can and should become, and what matching in healthcare can and should become. This expanded search on free text, on matching on free text, problem list and other clinical data, even claims data. It's new in concept for healthcare 20, 30 years ago. Now, while we're waiting for this modern magical search, we can do a lot of things to improve our current search as it exists today without even changing technology. One of the things I talk about quite a bit is the 3-finger search protocol. A lot of medtech shops adopt this because they're just has a very weak search capability. And what that means is they'll put the first or the last name rather in 3 characters, and they'll put a date of birth in. And the challenge is that that's only unique about 70% of the time, 70-80% of the time. So that means 20 to 30% of the time we're running the risk of duplicates and overlays, just because we are already missing part of the records that we're searching for because it doesn't match the first 3 characters. Or simply it's we get so many records back because it's not unique, we pick the wrong record. And that's a high risk, very high risk. Now, I give you an example with my name. I have seen my name spelled this way, each of these ways, over the course of my life. Sometimes I speak fast, people don't understand me. I don't enunciate well enough. And as a result, I have seen my name as Hoover with 1 O, Huber with a B, because the V and B sound similar. But the best is Hoover, as in Doctor Who, Whover. I've only seen that a few times, and it makes me laugh every time. Normally people think of vacuum cleaners when they think of my name, or President Hoover, but some people are clever and spell it Hoover. It makes me laugh. Really funny. But nonetheless, this fails that 3-finger protocol every time. Now, we know it exists for a reason, right? It exists because the search tools aren't clever enough or fast enough or smart enough, I should say, to find exact matches or inexact matches when we have text that's off by a character or 2. So we've all trained ourselves to type in less rather than more because we don't want to stop this search from working for us. And when we're searching for patients, this is something that we have adopted for sure. And that protocol exposes our providers to a higher level of risk for duplicates and overlays just because of how we're searching for patients. And even without modern search, we can do some smarter things. So one of the things we can do is to use a better search protocol. And we don't have a unique patient ID yet, a universal patient ID. And we can't really think of social security numbers as a substitute for that because industry is moving away from social security numbers. But what I have seen in the field that's really, really effective, and it's sort of it's a way to replace the notion of a universal patient ID because we might not have it, not soon at least, and maybe never. But think about it. Cell phones and emails almost always uniquely identify a person. Easy to misspell emails, easy to make errors in telephone numbers, I get it. Telephone numbers change, emails change, I get that. But they almost always belong to one person. And I have talked to a few patient access managers and professionals that search by telephone number first before they even look up the patient's name. And it reduces the search space to results to a much more manageable level. And as a result, it's a really good substitute for a universal patient ID. In fact, if we were to think about all the telephone numbers available to us, it's insane how large. And we could have a telephone number for everybody, and that's unique ID. And overlays are a brand new topic. Very few people talk about preventing overlays, but I think it's important now that we understand that we can find patients with a lot of errors. And I do want to preview some ideas on overlay records. This information comes from research, work out in the field, talking to practitioners and learning what they do in different organizations, and ways that some of us are attacking this really complex and difficult to solve problem. Overlay records, for the most part, are untouched. Very few organizations have processes to look them out, find them, seek them out, and even fewer software systems have any kind of notion of finding and managing and detecting overlay records. And it's no wonder why. It's really complex and hard. And it's certainly better to do error prevention, as the general theme of today's conversation is to stop them from getting into the system by having better front-end search tools to find patient records. But presuming we don't have that, or at least thinking about this, is the general notion is we have to go the exact opposite of the three-fingered search. We need more information at search time, not less. A fully specified record will rule out records that don't match. Blood types, allergy types, historical addresses, all the different versions of a name, a nickname example, can prevent us from assuming one patient is the same as another. This is especially problematic for people like me that have common names. So those with common names are at a much more, because their records are not likely to be unique. The names are not likely to be unique. So the more data we bring in and away from the three-finger salute, the three-finger search, the more likely we're going to find the right patient with additional data, not less. And that's a really critical thing a critical change in process. But it is something that I've found in practice in the field works much better to prevent overlay records. So my challenge to you is go ahead and type more. Look for more information rather than less. Do your best to use your current tool with additional fields, or find better tools that allow you to type in as much as you want and not worry about the accumulation of errors. Then we can make sure that we've ruled out the other patients. The fault tolerance of modern search eliminates the need to be 100% correct. So that's why I encourage you to do more, type more rather than less. But let's just say you've got an older search solution. The challenge is to figure out how much you can get away with within each field, how much error, how much plays in each field, to make sure that you can have a better protocol to type in more than just 3 letters of a first or last name or date of birth. And by the way, dates of birth are often wrong too. But the human bias in healthcare and patient access for sure is to assume that the date of birth is good. And I see this when we train machine learning systems, frankly, that learn from humans. You can tease out the bias in the output. But the human bias in healthcare and patient access for sure is to assume that the date of birth is good. And I see this when we train machine learning systems, frankly, that learn from humans. You can tease out the bias in the output to see that the date of birth is the singular most important factor in if records match. But you and I both know, all of us know if we think about it, that the date of birth is not special. It's just another data field. So it too can have errors. And when we use that with only 3 letters of a last name, we're very likely to miss records or to find the wrong record. But this only works with kind of modern technology. But one more thing I want to point out, at least in terms of healthcare process, is historical data also matters. If we track the changes in records as they occur in a medical record, we can see that last name is updated, a social security number might be updated, and an address. That's probably too many changes for one record at one time. The patient did not change all that information at once, most likely, and these are signals or tells to your HIM department that, if we monitor these changes in the medical records as they're updated from the EHR, maybe we can detect real-time overlays because we had just found new patient information overwritten an older record for different patients. And there's more to that. I'm going to have a lot more to say on that in the near future. But that's just a concept, an idea for you to hold and think about for overlay records. I'll leave you with a glimpse of the future. We've done a lot of talking about what's possible, what's current state, and what is possibly potentially future state. Modern search is right in the center because it's critical for all these things. Modern search and patient matching are the exact same thing. Search and patient matching are the exact same thing. Search just uses a few fields to find a record, and matching uses all the fields to match records. But it's the same basic principle. So we improve our search, we improve our matching. Clinical search I talked about, using patterns for searching. We can now search for, say, clinical data by example. For example, I can say, here's a template record from an EHR. Let's see how often this template is used in all the patient clinical notes, so we can root out how often clinicians use too much of a template for the clinical notes rather than something that's patient specific, because that will get us into trouble with the payers if we do not have patient specific data, enough of it. Infectious disease tracking, we can use patient matching to link addresses so we can see which patients are co-located, even when there's a high degree of variability in the addresses. I think that's critical. We talked about information blocking in the terms of what's coming new and how we need to find patients and let them download to their phones. But that presumes we can find the patient, so that's directly related to search. Overlays, we talked about a bit, so I'll leave that alone because we just finished. But population health is really, really cool because we're talking about clustering and grouping patients based on similarities, demographics, and clinical. But there's nothing special about either one of those types of data. What we like to do with population health is let the researcher, let the analyst say, I want to look at these 5, 10, 20 things about patients. Comorbidities, attending physicians, say medicine list, allergies, social determinants of health. Do they live alone? Do they have food insecurities and so forth? And also maybe where do they live? All that information can be combined into a temporary patient record that's built for every single patient we want to study, and then use modern search to cluster these records together based on the similarity or the patterns that appear in the records that we're trying to group. So really, really exciting push on population health, and I'll be talking about that more next year too. And lastly, discharge analysis. We talk about clinical decision support tools and patient matching with this pattern matching and machine learning is a very, very good suite of technologies to predict whether patients are at risk for being readmitted for the same illness or not. And if we have that prediction, then we can give better post-discharge care, different services to help the patient take medicines or get the physical therapy or whatever the case may be. Or in the case of social determinant health issues, maybe just make sure they have a ride back for follow-ups. Who knows? But we can use this suite of technology to make those predictions about certain patients to give them better care. And that's really what it's all about. Better care means reduced cost, and ultimately lack of readmissions means we're not doing the services for free because we can't bill for it if we have readmissions within a certain time frame. So that's all I want to say about population health and all these topics. I've covered them all in depth, at least in conversations. But really I want to talk, just leave you with this thought. Before we take a look at the EMPI toolkit, I'll give you a preview. Is I want to have us consider that failing to adopt modern technology, in this case search, we know that it's out there. We use Google every day, and failure to implement these kind of things in our healthcare systems, it's really not good, because we know we can find patients with better technology. We just have to push for that to make it happen. The EHR vendors are not necessarily going to do it for us. We have to, as users of the community, users of the tools, and as part of the community, look for better ways, look at different industries to adopt better approaches to solve our problems here. And so with that said, I do think we owe it to our patients and our organizations to lower our risk and mitigate it by being able to find patients easier. And with that said, all these ideas and many, many more, we folded into this EMPI toolkit that I did for California. And that's still in the review process. It's going to probably be another 6 months or longer before it gets published. But I think it's a really great thing for organizations, state and local chapters, to consider putting together. Our tools, commonality from our location, our area. What are the best practices in the north, the south, the east, the west, the bigger hospitals, the smaller hospitals, the nonprofits, and the big systems? What about the Department of Health are they doing that's so unique and interesting that we could probably learn and apply in our own organizations? That's what we get when we build these toolkits. I conducted 10, 15, 20 interviews over the course of 2 years for the California toolkit, and I think it's a great thing to do locally for maybe your guys' region too. It takes a lot of work, it's a lot of effort, but I think the outcome is best practices that are local and best practices that are actually potentially national in scale. Some of the ideas I presented today came directly from the field, and that's why I think it's important for us to think about developing these tools, because the best ideas come from places you don't even ever expect. So let me close out with sharing the concept, not only sharing the concept, but giving you a sense for what's in a toolkit that you might want to develop locally. I call this a modern approach to improving health information technology. It's all about stuff we collect in the field and bring it to others, as well as applying some science and new approaches, new tools, new thoughts that come from outside the industry. And I think that's really, really helpful. Took a team of about 20 of us to work on this. I was the lead and wrote the vast majority of it with a lot of help from editing and a lot of interesting ideas from the team. And most importantly, the HIM providers, leaders, directors, VPs, and managers, supervisors, and even patient access and their staff. What are some things we can do better? Search protocols, others. But we try to cover things like, how do we standardize our data? How do we improve the quality of our data? I touched on it briefly at the beginning of the presentation. Error proxies as an example. Naming conventions and looking at ways to maybe detect errors by implementing audits. Some hospitals I met over the past couple of years have really robust audit programs that specifically look for things like, how old are our consent forms? How consistent is the SOGI data as entered on the form that we can scan? How accurate is that entered in our MPI? Data quality issues. What fields are missing with what frequency? Are we trying to collect emails with enough consistency to make them useful for portal registration and patient search? We talked about, and so forth. Talked about some things like knowing your patient. Just like we can learn from other industries, the finance industry, they know their customer. That's a federal regulation because they want to prevent money laundering. But how can we take some of those ideas, knowing your customer, knowing your patient, to make sure we have the right patient ID? Some things to think about. We talk about some advanced technologies. We have no time for it today, but facial recognition, fingerprint analysis, voice recognition, and so forth. Even signature analysis. We have these soft biometric data available to us now, the signatures and the faces, and the IDs and the scanned consent forms and other docs. We should be using those for patient verification, matching, and ultimately anti-prevention of fraud. We go in depth on MPI cleanups and those kind of things. We talked a little bit about name errors today. And then most interestingly, I think, is supplying your community with a set of sample policies. Not every hospital has every policy, nor do they need them, but many can benefit from the group thought of implementing stronger policies for protections of our patients. Everything from pediatrics to transgender patients to anything you can imagine. How do we best identify those patients and then care for them, all in the policies as it relates to HIM? So that's just a brief overview of what is inside or can be inside an MPI toolkit. And it was the output or the outcome of 2 years of hard work, but based on my 7 years of time in the field, plus 20, 30 years plus of the members on the team, and outreach into the community. So it's a real great outcome from having an organization do this kind of work for the members. Anyway, that's my warning to get off the the call. I've been on for a while. You can see it's gotten dark in the back. But thank you so much for attending the presentation. I am very, very sorry I could not be there face to face, so to speak. But I am available for questions and comments. My emails, etc. are here, and I think I put them in the beginning as well. So feel free to reach out to me, ask any questions you have, and I'm happy to address them to the extent I know the answer. And I apologize if it got to be too deep too often, but I am that bit of a computer science nerd. So I would not be living up to my reputation if I didn't. Anyway, thanks so much. Have a great night, guys, and hopefully see you live in person real soon at the next get together. We'll be there if you guys invite us. Happy to come. Take care.